All right. Good afternoon. My name is Brenda Schaefer-Pellenin, and I am a planner with the Arrowhead Area Agency on Aging. I'd like to welcome you and thank you for joining us for today's session, Dementia Conversations. Before we start, just a few housekeeping items. Today's session will be recorded to share on our Arrowhead Area Agency on Aging YouTube channel. I encourage you to subscribe to our channel so you're able to keep up with the latest additions to our video library. We are always looking for suggestions for future webinars. And if you have suggestions for topics or speakers, please feel free to share those with me and I will include my email in the chat. Please do keep your microphones set to mute. Just a note, if you do experience any issues with your bandwidth or audio quality, it does sometimes help to disable your camera. If you'd like, you can enter your first name and your organization or community that you're from in the chat box. Also, what you're hoping to get out of today's session or how you found out about it. If you have any questions during today's session, you can certainly enter those in the chat, or you can just hold those. We will take questions at the end of the presentations when we get to the end. At the close of today's session, you will see a quick evaluation will pop up on your screen. We ask that you take a moment to complete that survey. It does help us greatly when planning future sessions. And just a quick reminder to visit our Facebook page for more information about other upcoming sessions. You can also check out our website at arrowheadaging.org. So let's meet today's presenters. Danielle Freitag is a regional care consultant for the Alzheimer's Association, Minnesota North Dakota chapter. She serves in Northeastern North Dakota, including Grand Forks and the surrounding counties. Danielle received her master's in aging studies from Minnesota State University, Mankato. Danielle has over 10 years working with people living with dementia and families, including in long-term care, community support organizations, and at area agencies on aging. Danielle has worked for the Alzheimer's Association since January, but served as a volunteer and an intern prior to that. Danielle provides care consultations with families and professionals, professional education, and promotes community partnerships in Northeastern North Dakota through education and outreach. And Forrest Clark has been an occupational therapist for over 40 years. The past 24 of those have been with St. Luke's, and she is their driver rehabilitation coordinator. She's also the owner of Safer Driver LLC, a driving school that specializes in assessing elder drivers and drivers in need of vehicle adaptations. Anne's goal is to help keep our roads safe for drivers and passengers of all ages through assessment of driving skills, training to improve skills where possible, and supporting driving retirement if that's indicated. And last but certainly not least, Kristen Parento is the managing attorney of the Duluth office of Legal Aid Service of Northeastern Minnesota and specializes in elder law and has for 20 years. She graduated from the Mitchell-Hamlin College of Law in 2001. And Kristen lives in her childhood home of Esco, Minnesota, where she and her family raise cows and chickens for fun. So to start things off, what we're going to do just really quick is I'm going to pop up a poll, and we just kind of want to get an idea of where everyone is coming to us from. So if you're an aging services professional or a human services professional, if you're a community member, if you are a volunteer with a community organization. All right. So pretty solidly, folks working in aging services are human services professionals. So thank you for sharing that information. Now I will turn things over to Danielle.
Thank you, Brenda. I'll go ahead and share my screen. Today we're going to talk about, like Brenda mentioned, Dementia Conversations, and the presentation that I'm going to share with you. I know you're not supposed to have a favorite presentation, but it's definitely one of my favorites because I think talking about conversations at the beginning stage of dementia is so important because it gives you autonomy, it gives you independence in the way your life is going to progress as you develop the disease. Can you see the screen okay? Okay. I will go ahead and start the slideshow then. So I'm Danielle Freitag from the Alzheimer's Association. Like Brenda mentioned, I work in North Dakota, so not in Minnesota, and I currently don't have any snow, which is wonderful. We're getting big storms, but I'm with the Alzheimer's Association. And like I said, this presentation is all on dementia conversations. And it's really designed to help you communicate with either the person living with dementia or the family members about those conversations that can be really challenging to have. And there's a lot of fear surrounding dementia and Alzheimer's and these difficult conversations. There's fear around facing age changing and being forced to manage difficult family dynamics. And you may want to wait until that time is right to have these conversations, but in reality, there really is never the right time. I always tell constituents when I work with them, the right time is the soonest time. Other than that, there isn't a perfect time to have these conversations because you never know what's going to happen. And my slideshow has a mind of its own, I guess. So it's telling me to go on to the next slide. But so the changing needs of the person often signal that it's time to have a conversation. We have heard, and I have heard through care consultations from many people that some of the most difficult conversations that you have with someone experiencing symptoms in dementia are around going to the doctor to get that diagnosis or to receive care, deciding when it's time to stop driving, and making plans for the future. So whether that's finances or legal documents, just making sure those person's wishes are carried on as they work through the disease. And keep in mind too, as we have these conversations, we offer a variety of approaches, but not all will be appropriate to your loved one with dementia or someone you're working with that is experiencing symptoms, because dementia is one size fits all. So the approach will need to be accustomed to the person that is living with dementia. So today's program, I will share some tips for breaking the ice and having difficult conversations around some of the most common issues that arise when someone is exhibiting or experiencing symptoms of dementia. Help you plan ahead and build a care team that will work and communicate well to reduce some of the stress that can come with that of dementia or Alzheimer's disease diagnosis. Give you the opportunity to hear from people who are dealing with similar issues, and they share how they handle those issues as well. And connect you with helpful resources to enhance the quality of life for everyone that's involved. So a lot of times when I'm talking to someone, you hear them say, well, I'm not a caregiver. And so maybe you don't see yourself as a caregiver, but you might be noticing some changes or signs in the person you are caring about or that are causing you some concern. Often we find ourselves wanting to avoid talking about that and having those difficult conversations around issues for several reasons. So sometimes the person says, I'm fine, I don't need help. Or we assume another family member who lives nearby is going to take care of that. Maybe there's fear, there's a loss of independence that might come with someone's diagnosis. We have a fear of taking that away from them. Or the family members disagree about whether there's a problem or not. But like I said, sooner is definitely better than later. You don't want to wait for there to be a crisis to have these conversations. You can actually try and help avoid a crisis by talking about these issues and taking action in advance. So by talking early in the disease process, you'll be able to hear directly from that person who is living with dementia about his or her wishes while the person can still contribute and be a part of that planning process, which is so, so important. Despite the difficulty of having these conversations, they need to take place to ensure the person's safety and well-being. Successful conversations start with being prepared in advance. So you want to develop a plan on how to finesse the conversation, how to introduce the topic in a way that will be gentle and minimize resistance. And the use of finesse goes beyond that honesty. It can involve understanding how difficult this conversation can be and thinking about how to best gently position the discussion for a positive outcome. Also consider what you will do regardless of how the person responds. So for example, you might have these conversations about, do you want to know if I start to notice changes in your functioning? And more often than not, the person will say yes, but there is a chance that they will say no. And in the case that they do say no, you want to think about those emotions that are underneath that. Often it's fear, often they're scared to see changes. They're scared to acknowledge what's going on. So you might have to have a conversation later about those changes and acknowledge the feelings and the emotions that are happening when they do say no. Take notes about the changes you see. Begin observing and note examples of the behaviors that concern you. Take notes after you see something of concern so you can accurately talk about what you've noticed, and write things down so you don't forget the important points you want to cover, and bring those notes with you to that conversation you have with that person. Be prepared to talk about your own feelings too. Use those I statements. Try to avoid suggestion though, or placing blame or criticism on that person, as you know, they might get defensive or angry. And be gentle in your discussion, keeping the person's feeling in mind. You want to avoid having that person have a sense they're feeling or they're being ganged up on. You also want to try and practice in advance. Rehearsing talking about sensitive topics with other family members will help you feel more comfortable when you have an actual conversation with the person exhibiting or experiencing dementia-like symptoms. You can consider possible solutions to offer during that conversation as well. And initiate that conversation at a place and a time when that person is relaxed, well rested, and comfortable. A lot of times with someone with dementia or someone experiencing symptoms of dementia, the afternoons are tiresome. They're exhausting. They're not feeling their best in the afternoon. So maybe it's in the morning during their coffee or they're feeling good. So when someone in your life exhibits changes in thinking or behavior, it's important to be aware that they could be signs of Alzheimer's or another type of dementia. There are changes that are typical of aging, such as, maybe taking a little bit longer to remember names, especially if that's something you've never been good at, or needing a reminder about how to use the remote control. But you may start to notice issues that go beyond that of typical aging. So maybe that person is getting lost in familiar places, or they're withdrawing at social events. Maybe they're asking the same questions repeatedly or forgetting recent events. A lot of times we look at what is something that person has always been good at. Maybe it's bills. They've always religiously were able to manage their bills, and you start to see struggles in that. Well, that could be a sign. Whereas maybe myself, who's not so good at that, as I age, if that continues, it's maybe not necessarily a sign of dementia. It's just who Danielle is. Conversations can go much more smoothly if the reference is made to these changes rather than those that the person has not noticed in his or herself. Sometimes that person might be reluctant, fearful, or angry when you encourage them to seek help. This can be because of his or her feelings about the disease, maybe the effects of the disease themselves, or it can also be cultural beliefs or stigma surrounding dementia or Alzheimer's. But we do have some tips that can help you get the individual to that doctor. It can feel really awkward to approach someone about the changes that you've noticed, but many times that person has noticed changes in themselves already. The person might be afraid and in denial. This is one of the most basic ways to protect ourselves from feeling overwhelmed. But the changes might be due to something other than Alzheimer's disease. So acknowledge this, and this can help encourage the person to go get medical help. So here in this video, we're going to hear from Donna about the importance of having this conversation. And I'm not sure if I shared my sound, so Brenda, if you want to give me a nod.
I think you have to be honest. I think that's the important thing with it. To get a loved one to the doctor, I think you just need to be candid and honest of what are you trying to do. We're trying to understand what we're up against. It's just so important to do that, because you can't battle something that you don't know what you're battling. Again, it may not have been Alzheimer's, it could have been depression, it could have been so many other things. And guess what? There's other things you can do to take care of those issues as well. But that's what you need to be able to do. You can't ignore something, it's not going to go away.
So suggesting a doctor's visit can be all that is needed to get the person to the doctor, get that ball rolling. Other times, just being honest and direct isn't enough, and the person needs more support or direction. So here are some ideas that can help. Start by trying to use words that are most comfortable for the person. Be aware the person might be sensitive to words such as Alzheimer's. So you might want to say, let's go to the doctor and talk about the fact that you're having more trouble doing things than you used to, rather than saying, we really need to go to the doctor to see if you have an Alzheimer's disease diagnosis. You can let the person know that it's time for their annual wellness visit. The annual wellness visit has been offered by no charge by Medicare since January of 2011. And it's a visit developed to update a personalized prevention plan that can help prevent disease and disability. So it includes an examination of the patient's cognitive and behavioral changes that may indicate a form of dementia like Alzheimer's disease. Many older adults have not heard of this benefit, but taking advantage of it can be a way to get the person to have their cognition evaluated. And I will say, if you do make one of these appointments, make sure you mention when making that appointment that you want the cognition evaluated, because sometimes those cognitive exams can be short. So keep that in mind as well. Pair going to the doctor's visit with an enjoyable outing. So maybe you say, hey, let's go to the doctor and then we'll grab some Dairy Queen afterwards, or get your favorite cheeseburger from McDonald's. Invite family to communicate concerns and questions to the doctor too. Whether you are able to be there for the appointment or not, you can prepare a list of your concerns and questions and provide that information to the doctor before the appointment. And even if you are able to get that information to the doctor, keep in mind that because of doctor-patient confidentiality and regulations with HIPAA, that doctor might not be able to communicate back with you. So it's important, if the person that is living with dementia or experiencing symptoms, if they agree to get a signed release, that's always a good idea, because then you can communicate directly with the doctor. And there's still a chance the person might be reluctant. So if they are, you can try using what is called a therapeutic fib. So there might be times when the person exhibiting or experiencing symptoms is extremely reluctant to see a doctor, regardless of your attempts. So the person exhibiting or experiencing symptoms often experience a reduced ability to use good judgment and make good decisions. Sometimes this can contribute to the person reluctant to go to the doctor. So in these situations, the person's safety and care comes first. You may need to utilize a technique called a therapeutic fib to get the person to visit the doctor's office. To get someone to see a doctor, some family members or friends tell the person the doctor's visit is required to get a prescription updated, or it's required by Medicare. Invoking this outside authority can help the visit to seem less like a criticism of the person and his or her current level of functioning. So hopefully resistance is reduced and you're able to get that person to the doctor. I just worked with a gentleman who didn't want to go to the doctor because he didn't want to pay for gas to get there, since gas is a little bit expensive right now. And we suggested that they say, hey, therapy is covering gas for us right now. And that was all it took to get him to go to the doctor. So other than going to the doctor to get a diagnosis, another conversation that can be difficult to have is driving. And honestly, this is one of the most difficult conversations that people have expressed. You may notice signs that your family members' ability to drive has changed, such as accidents, they're getting tickets, moving violations, or maybe there's new scrapes on the car, new scrapes on the garage. Or maybe you're even in the car with the person when they made a mistake that was concerning to you. So even though many of us will need to stop driving at some point, people are often reluctant to consider this issue because it does relinquish some of your independence. Denial that anything is wrong can allow a dangerous situation to continue, but dealing with the issue early on can help ease that transition. So here we're going to hear from Chris about how this happened in his family.
There's no exact answer on this is when you stop driving. You could tell when coming up to an intersection, as an example, the ability to understand what's going on around you was starting to deteriorate a little bit. Being on the highway with cars on both sides becomes a little bit more difficult. And first and foremost, the safety of everybody in the car as well as other drivers on the road. You think about that and you want to make sure you're not putting anybody in danger. But then the difficult part is telling your dad, who you love, and you know he loves driving and he's used to it, that he can no longer do that. But then even then, taking the keys away full time was very difficult. The doctor was very helpful in just saying, medically, you can't do this anymore. But my mother had the hardest time with this because she knew how much this was going to hurt him as well. And this is one of the first things that we had to deal with as a family when it came to telling my dad that he had to stop doing something because of this disease, that meant a lot to them.
So whether the changes in driving are due to Alzheimer's or another form of dementia or not, here are some tips that people have found helpful when discussing this sensitive topic. First being plan ahead before an accident happens. Before changes in the ability to drive or see, and talk about the fact that the person will need to stop driving at some point. Many families find it helpful to have an open discussion and develop an agreement about how the person would like to recognize that it's time to stop driving. Such as you're noticing more scrapes on the car, or they're getting more tickets. And when the time comes, the person may not remember the conversation. So it can be helpful to write notes about your agreement to use later, or even ask that person to sign a driving agreement. Say, if I have X amount of tickets, then I will stop driving. Or if I see X amount of reasons that I should stop driving, I will stop driving. Express your concern about the specific changes that you have noticed. Let the person know that you care about him or her and support him or her, and reinforce that as the reason for your concern. So for example, use specific examples. You can say, last week I was driving with you and you went straight through 2 stop signs. That really concerned me. You can also try appealing to that person's sense of responsibility and concern for others. So for example, you could say, I really know you don't want anybody to get hurt. Maybe we should consider stopping to drive. And in this next video, we're going to hear Sheila talk about how she approached this with her father as well.
Some tips on having the conversation is pointing out, especially for my father, the potential danger to others that it may cause if he's behind the wheel. And just talking about it from the standpoint that this is not only the best thing for you, but this is also the best thing for others around you. And these are some of the alternatives, making sure that this is what's going to happen, having a plan. If mom can't take you, then Uncle Thomas or will be here to take you, and we will make sure that you're getting out of the house and that you're doing some things. So, presenting the bad news, but then also presenting the plan. And for my father, that's really, really important to have a plan.
Yeah, as Sheila mentioned, having that plan for alternate transportation in advance is so important. You want to be sure to include transportation to places that will help the person maintain their social connections and hobbies. Maybe they want to go to the grocery store, or to a church, or to quilting club, whatever it may be. Making sure those plans are in place prior to the conversation can help it go a little bit more smooth. You could also try incorporating the voice of an esteemed professional and have empathy. So you can ask a physician to write a letter or prescription stating that person must not drive, kind of like Chris mentioned in the video. And use empathy in your conversation, and think about ways to foresee and minimize the person's sense of loss. You could consider talking about it as a method of retiring from driving versus telling the person that it's time to give up driving. And next we'll hear another video about Wendy, who's going to talk about a key component to making a conversation a successful one.
Talking to somebody about stopping driving, I think it's most important to understand that that is tied to someone's independence more than most things. And so by saying you can't do this anymore is like telling the person, it's like ripping away their independence, and that doesn't feel good for anybody. I know that I've always tried to put myself in that situation. What would I think if someone was saying this to me? You don't get to do this anymore. And how would I feel, and how would I want somebody to talk to me about this? And so if you try to I think sometimes too many people try to approach it as, very punitive. And I'm doing what's right for you, so why don't you understand, without really turning the tables and putting themselves in that position, understanding, how helpless that feels to take those things away. It's important to be thoughtful about what that experience is like for the individual.
Yeah, we've talked about independence a lot throughout the presentation, how important that is. And another way that someone does maintain independence for themselves is by making legal and financial plans for their futures. Many families do this, but only to be taken by surprise when dementia enters the picture. So as medical and long-term care costs in the US arise, Families may need to step in and provide care and help with a person's finances. And we'll hear from Chris again about how he managed this with his family.
Financially, this disease will increase the cost of living. It's just a fact. So planning for those extra costs is that much more important than what you were planning for before. And so you have to review everything that's in place, see what changes need to be made, both legally and financially, and you have to monitor that going forward afterwards too.
Some people may have plans in place but still feel uncomfortable discussing financial status with you. You may also feel reluctant to do anything that may come across as intrusive to the person, but it's still really important to talk about it. Making legal and financial plans early ensures that the person's preferences are included in those plans, and the family will not have to make rash decisions in a crisis situation. It's important to take the time to have these conversations. They can be really scary, but they're very, very necessary. And in this video now, Julie's going to tell us about how she talks with friends who ask her about having these kind of discussions with her mother.
Here's what I've come to after all of this. That it's the most loving and kind thing you can do for them is to be honest with them and say, this is like a really scary thing. And I feel a lot of discomfort bringing this up to you, but you know, I tell them, if you're going to be the one who's going to take them on this journey, then you have to tell them, I'm going to be here on this journey with you. And there are things that we have to do to get this in place. We're going to go on this journey together. I've told you I'm going to be here with you till the end. So let's get this ready. It's like we're going to go on an ocean ship. We've got to get things packed up. We've got to figure out what we're taking with us. We got to get ready. And the things that we have to get ready, we have to make sure that we know which doctors you're going to be using. I need to get this signed, okay? So that if you go in there and they have to do surgery, for example, I got to have this durable power of attorney for healthcare for you. I have to have this worked out, okay? Now, if for some reason, okay, you need to go to rehab after something, I have to have these documents here, the financial stuff, so I can get these things taken care of for you while this is going on. I don't want to have anything get in the way of us being able to progress and keep doing this. I said, it seems hard because it's hard in our heads. You know, everybody's read about people who've stolen from elderly people, who've done these horrible things. But if you're the person who's approaching this with loving kindness and compassion, and you're willing to take this person on this journey, you're not doing a bad thing. You're doing the right thing by talking to them about it. And you approach it from the standpoint of, I'm here for you. I'm doing this for you. We're going to do this together. And I'm going to help you through this. And these are the tools that I need to make sure that we can do this.
I really like when Julie says we're in this together. It's a partnership. It's not that person living with dementia on their own figuring this all out together. Some of these discussions might seem like they go against some of our social norms, and they might represent a shift in family roles. But understand that having this conversation will help you and the person living with dementia make the plans you'll need to get the best care, and will allow you to connect and enjoy your time in the future. It can be tremendously reassuring to let the person know that you will be a part of this process now and in the future. This way, the person you love can feel like you're on the same team. Start by asking questions and gathering documents. Think of the conversation as a chance to ask questions rather than telling the person they need to do something. So you can ask, what documents are in place now and where are they kept? Who has copies of the documents and who should have those copies? Who should review these documents? Can the family do it? Do we need to talk to a professional? Pull these documents together and take care of any that need to be completed or altered. And you can explain that these are all standard plans that need to be made as we get older anyway. You can help reduce resistance to the process by explaining that having these discussions and completing these documents are things we all need to do as we age. And you can try and break that conversation into parts, try different times, different locations. If you had that conversation over the phone, maybe try in person next time. Maybe write it in a letter or write it in an email if that seems an easier way to initiate it. Don't feel like you need to cover everything in one sitting either. It may help to do some planning in smaller segments. So maybe one day you can address someone's finances, the next day you can talk about legal decisions. You can also involve others to help talk about finances. So ask a financial advisor to help with the conversation or involve a brother or sister who maybe are good at these conversations. Some families make decisions to pool resources to ensure that care can be provided and the expenses paid. It's important to understand the financial situation so your family can help make the best long-term care choices in the future. And just as having these conversations are challenging, caring for someone with disease is also challenging, but there are steps you can take to make things easier for everyone involved. As some of our seasoned caregivers tell us, no one can do this alone. Everyone who provides care for the person is part of a team, and care teams work best when there is good communication. The first step is to begin the conversation by talking with others in the care team. And as with any team, your team works best when there is an open flow of communication and when decisions are made together. You, the person living with dementia, and your other family members are at the center of that team. And whether family members live near or far, everyone can still participate in that team. Next, families typically look towards their primary care doctors to help with making medical plans. Other medical professionals who specialize in the area of dementia care may also be included to help make a diagnosis, such as a neurologist. And once that diagnosis is made, find out who will coordinate care on an ongoing basis. And this is more often than not the primary care physician, but there's more to the care team still. Peers can be a tremendous support to the core team members. As the disease progresses and care needs increase, friends can offer a much needed break and emotional support to that person caring for someone living with dementia. We encourage everyone that is part of the care team that continues to work to contact their company's HR department or the Employee Assistance Program to ask about caregiving benefits. Families can then look at their pool of resources and make decisions about how to proceed. There are also community resources available where you work and live. Some are even online, so your entire family can have access to the information and support. And as part of one of those community resources, the Alzheimer's Association is always there to provide any support that you need, beginning with our Alzheimer's Navigator, which is a tool that allows your family to create a personalized action plan to connect you to local resources, information, and support. We also have our community resource finder where you can look and find education, support group, whatever it is you need. We have our 1-800 helpline number. This is available 24/7, 365. Christmas Eve at 11:59. You have a question about a challenge you're having or a resource you're looking for, you can give them a call and someone is there to answer. We also have many ways to get involved. So you can join the Walk to End Alzheimer's, which is one of our biggest ways to get involved. Here in North Dakota, it occurs in September. I'm not sure about Minnesota, but around that fall area. But it's a good way to connect and really work towards that end of Alzheimer's. You can also volunteer. You can be a community educator and give classes such as this one. Be a support group facilitator. Be an advocate. Lots of ways to get involved with the Alzheimer's Association. And like I said throughout, no one can provide all the support alone. So form a good team and talk about your concerns as they arise with your family, with that team, with community resources that are available. Just know that you're not alone. And here again is our 1-800 number. And I just want to thank you and Brenda for letting me give this presentation.
Well, thank you so much for really Danielle, for helping us kind of set the table for these discussions and giving us a good foundation. And we're going to turn things over to Anne so we can do get a little bit more of a deeper dive into the driving issue.
Good afternoon. I'm going to share my screen with you here. There we go. So our topic is driving and dementia, independence and public safety. I echo the things that were discussed during the last presentation, especially with regards to driving being more than just the operation of a motor vehicle, but it's very much a level of independence, a marker for adulthood when we finally get to drive as a teenager. And it's a great loss when people age and are told they can no longer drive. I've had many clients that I've worked with say, I'm going to go home and die. This is the worst thing that's ever happened to me. It can be extremely emotionally charged, an emotionally charged situation for folks. It's very important just for basic access of the community for basic necessities like grocery shopping, medical care, veterinary care, and to engage with your friends, your family, your church. During COVID here, I live very rural in Duluth. There are no delivery services. No way to get food when we had COVID. The only thing we could, and everybody was afraid to, have contact with us. The only thing we could do was to order online, and then they pushed the cart out towards us at Cub. If I couldn't drive, we wouldn't have been able to get groceries at that time. It's important to know that driving is a government-controlled privilege. Each state sets its own laws and rules. More than once, I've had people say to me, I'm an American citizen. It is my right to drive. That is not true. Driving is a government-controlled privilege. I also want to make sure everyone understands that medical fitness to drive is not dictated by a specific age. So you turn 85, boom, you should stop driving. That is not true. What it's determined by is a person's health status, your physical skills, your visual skills, and your thinking skills. However, the aging process can and does affect some of these skills. And dementia can magnify the effects of aging. So they do go hand in hand, but it's not age alone or that diagnosis of dementia alone that indicates when it's unsafe for someone to drive. I like to share a couple statistics with everyone. In the state of Minnesota, about 20% of the total drivers are over the age of 65. However, they only make up 16% of the crashes. So that's a good thing. We've got 20% of the drivers over 65, but they only are involved in 16% of the crashes. But look at the next one. They represent 25% of the deaths. What is going on here? We have only 20% of the people on the road over the age of 65, but they're 25% of the fatalities. There's a concern, and that's because going into an accident when someone is older, you are more vulnerable, you have more health vulnerabilities, meaning bones are more fragile, you're slower to healing, and per mile driven, the fatality rate beginning at age 75 rises very quickly for people that are involved in a motor vehicle accident. So it's not necessarily the accident that causes the death, but it might be the surrounding healthcare issues. Many times people will develop pneumonia that will take their life. So going into an accident when you're older can have a very bad outcome. So what's causing the accidents for people that are older? People involved in a single vehicle car crash are more often, the crashes are related to running off the road, such as falling asleep or getting confused, and using the wrong lane. Those are the areas that people over the age of 65 are most experiencing in single vehicle crashes. If they're multiple vehicle crashes, the reason why people over the age of 65 are getting involved in accidents is failure to yield. And that's specifically not knowing whose turn it is to go at an intersection, or not seeing the stop sign and going through the stop sign. Those type of accidents are the highest cause of multiple vehicle crashes for people over 65. So what are some of the normal physical aging changes? And I'm 61 and I'm feeling every one of these. Our reaction time slows down. Our joints are less flexible. We're not as strong as we used to be. Our endurance really declines as we age. We just can't do what we used to do. I used to be able to work all day, drive to the cities, attend a meeting, drive back and work the next day. I can't do that anymore. I am too worn out. I have to take the next day off if I do that. Our balance also declines as we age. Dementia magnifies the effects of aging, and it can be both physical, visual, and cognitive effects. It makes people less able to compensate for those effects. So signs of physical concern that relate to driving. If someone has pain in their legs, knees, ankles that limits movement, so they might be slow moving their foot from the gas to the brake. If people have a walking endurance of less than a block, that's a big warning sign. If a person is falling, statistically, they're at a 40% greater chance of being involved in a motor vehicle accident if someone is having multiple falls. Decreased neck rotation, not being able to look over your shoulder to check for vehicles in your blind spot, not being able to raise your arms above your shoulder, and having difficulty gripping the wheel and operating other controls in your vehicle. Those are some of the physical signs of concern that I look for. So what do? Number one, you need to manage your stiffness and swelling, meaning see the doctor. Find out if there are medications that can help you with those issues. Get involved in an exercise program that includes walking, stretching, and balance work. And consider adaptive options, such as adding a panoramic mirror or different seating, steering devices, even hand controls. I would only recommend adding adaptive equipment such as hand controls if someone is in the very, very early stage of dementia. I would never recommend that for someone that's a little farther along in the process. Some of the visual skills related to driving. The statistic out there is that more than 90% of the sensory information that we use to be able to make decisions regarding driving comes from our visual system. That leaves 10% for touch and balance and hearing. 90% of the information that we use to make decisions driving comes through our eyes. Most states only have standards that relate to our sharpness of vision, our acuity, and our peripheral fields. However, we know that there's much more to vision than just those two measures. An optometry conference that I recently attended identified that contrast sensitivity is a much stronger predictor of driving performance than sharpness of vision. And I've got a slide later on that will show what that means. So normal changes in our vision that are caused by aging. We're going to see a reduction in the sharpness of vision, our acuity, a reduction in our glare recovery, meaning if we're exposed to a bright light, it takes longer for our pupils to relax and be able to see after that bright light exposure. Think if you've tried to go to a movie theater and you walk into the theater and it's very dark. It takes longer for your eyes to be able to relax and see in that lower light situation. That's what contrast sensitivity is. Depth perception decreases because our eyes are working less efficiently together. And the biggie is our scanning speed. We're not able to move our eyes as quickly as we did when we were younger to take in information. In the state of Minnesota, the sharpness of vision law is graded so that there are some people that can drive with lower levels of vision. Say, for example, your sharpness of vision is 20/50. You're restricted to roads of less than 55 miles per hour and daylight only. If your acuity is 20/60, you're restricted to roads of less than 50 miles per hour. So that doesn't mean you can drive on a 70-mile-an-hour road at 50. No, what it means, the speed limit on that road has to be 50 miles per hour or less. In Wisconsin, they don't have a graded approach. Their law says 20/60 vision or better in at least one eye. They don't have the stepped model that Minnesota does. The peripheral fields limits in the state of Minnesota, we must have a 105 combined field of view. So if you look at my picture down below, a person, you're looking down on top of the person, let's say they're using their right eye, they are able to see all the way out to the right side and then partially over into the left side, and that will be 105 degrees field of view. If you think of it, directly in front of you would be 90 degrees, a little bit over for 105 degrees. That's pretty restrictive because many people that have advanced glaucoma, many people that have monovision, meaning the use of only one eye, sometimes have difficulty meeting that field of view limit. The state of Wisconsin is a little more generous. They allow people to drive with a 70-degree field of vision. So that means they don't even need to be able to see past that middle point. They can have a pretty restricted field of view. Just different laws, different states. Glare recovery, as I described before, our pupils' ability to respond quickly if we're exposed to bright light. That means both your eye has to need to constrict if the bright light comes at you, but then also be able to relax when that bright light goes away, because when it constricts, we're not able to see as well in a lower light situation. And then contrast sensitivity. That's our sharpness of focus in low level light situations. It reduces or gets worse as we get older, especially if we have cataracts that have not been removed, and we're seeing people that have dementia have a much greater difficulty when the lighting is lower, being able to compensate and see clearly. So here you can see a representation of what 2030 contrast sensitivity might look like versus 2070 contrast sensitivity. You can't even count the number of vehicles there on the road. Depth perception is definitely affected because our eyes don't work as well together, and we need the two eyes working together in order to perceive depth, especially if someone has a field loss. They don't even realize that they are limited in their depth perception. And this is where you start to see people having difficulty with the scrapes and the bumps, especially hitting stationary objects like mailboxes and the side of the garage and the garage door, those sorts of things. Their depth perception, that's a sign that depth perception is impaired. And then lastly is visual scanning speed. That's our ability to scan quickly in a situation, identify the pertinent details, and make the appropriate response. So here's an intersection. You guys know where that is, or no, not everybody, because you're not all from Duluth, but this is the freeway going into downtown, and you need to be able to be in the right lane to get where you want to go. That intersection is now under construction and a little more simple to navigate because it's only down to 2 lanes. But you have to be able to identify quickly, oh, what lane do I need to be in? So signs of concern regarding visual fitness. If you're struggling to read signs, that's an issue. You're significantly reduced in your amount of time to react to those signs if you're struggling to read them. If you're not able to see the lane markings on the road, or not able to detect the curb from the roadway, you're having difficulty seeing, smaller objects such as pedestrians or deer or what have you. If you're blinded by glare from oncoming headlights, or if going from dark to light, if you're struggling with that situation. In Duluth, we have 3 tunnels that you go through if you're traveling through downtown, and you go from bright light to dark, to bright light to dark, to bright light to dark. And that's often difficult for people that have issues with glare recovery. If it appears that people or objects are coming out of nowhere, like all of a sudden, boom, they're right in front of you, that's a key that you maybe have some reduced visual fields, and you're not able to identify objects quickly enough to avoid them. And not being able to follow something that's moving very quickly, like a car going across. One of the key markers of dementia is a reduction in the cells in our retina that detect movement, moving objects in our visual field. So people with advancing dementia have significant difficulty processing moving information, moving objects in their environment. So how do you help if you're having some of those visual issues? Number 1, wear your glasses, make sure they're clean and the prescription is updated. Don't walk around with that prescription in your purse for 12 months. Get the new glasses when they're recommended. Definitely see the eye doctor annually. And if the eye doctor recommends cataract removal, do it. It's the single most easily rectified cause of poor vision. Cataract surgery is almost minimally invasive these days, and recovery is very quick compared to years ago. I'm scheduling my cataract surgery within the next month because my vision has declined to the point where it's necessary. You want to avoid driving in low-level light situations, such as night or at dusk or at dawn. You want to make sure that your windshield and headlights are clean, especially if you are lucky enough to have a vehicle that has those little backup cameras. Make sure that backup camera is clean, because that often, especially at this time of year, is getting splattered by mud and what have you. You want to turn up the light level on your dashboard. All dashboards have, in newer vehicles, anything I'd say newer than 2000 has the ability to increase the light level on the dashboard. So it's less of a struggle for you to move from the bright light situation on the road to seeing the dashboard. And then use glare protection. Make sure that you're wearing sunglasses that wrap around and protect the light that's coming in from the side, or consider a visor shield that will help reduce some of that bright light that's coming at you. Some cognitive changes that can happen as we age. All of us feel it when we notice we aren't able to do exactly what we were able to do when we were young. We can't take in information as quickly. We need more time to make some decisions because we just need to think it through a little bit more. We have a greater difficulty attending to multiple things at one time. Our divided attention reduces as we age. We might be experiencing some reduced short-term memory. We can remember what happened 20 years ago, but it might be hard to remember. Did I take my pills this morning? And lastly, as we age, we start to use increased amounts of medication, and different medications can affect our thinking skills also. So what are signs of concern related to thinking skills and driving fitness? Being overwhelmed by signs, signals, and road markings. People are that live outside of Duluth are very afraid to drive in Duluth because things are so busy and there's signs everywhere. Having difficulty judging intersections. For example, who goes first? You come to a four-way stop, whose turn is it to go? Having difficulty merging or changing lanes. Many people will not be able to safely make a lane change or know the sequence and how to do it safely. How about becoming confused or lost while driving? Especially if it's a familiar location to which you've been driving many, many times before, but yet you become confused. Big red flag. How about not being sure how you got to a destination? You're all of a sudden where you need to be and you can't remember the path you took to get there. Or how about not being able to find your car after you've parked it in a large parking lot like Walmart or Menards, and geez, where did I park? Becoming sleepy after you've taken medications. That is a huge concern, and more people fall asleep at the wheel and cause fatal accidents than you would expect, but it happens. And also having difficulty remembering and organizing and taking your medications is also a big sign of concern. If someone's needing help to remember to take their meds or setting their medications up, that's a big red flag. So what can you do? Make sure you're driving defensively. Take a class. The mature driver classes are offered by AAA and AARP. Those classes are very helpful. If you're going to a new route, plan that route and even do a trial run on a day when it's not so busy with another driver to help you find your path. Limit your driving to familiar areas if you are having difficulty reading traffic quickly. Try to drive at lower traffic times. Definitely avoid driving during bad weather. Minimize distractions. Make sure the radio's turned off. Don't try to eat or smoke a cigarette or take a drink from your pop or whatever while you're driving. Hands on the wheel, eyes on the road. And don't have conversations with other people. You need to keep your head in the game as you drive. And absolutely no alcohol if you're driving, especially as we get older because of the number of medications. They don't mix with alcohol. It is not okay to go out and have dinner and have a cocktail and drive. It reduces our reaction time and it's not safe. Don't drive until you are sure you know how the medications affect you, because a new medication can really cause some drowsiness, can cause some foggy thinking. You need to know how it affects you before you get behind the wheel. And don't drive when you're tired, because like I said before, people fall asleep at the wheel and cause very bad accidents. So we want to keep it safe for everybody, because driving is the most dangerous activity of daily living that we do every day. We are usually doing it alone, so there's no regular feedback. Somebody's not telling us on a regular basis, hey, you missed that stop sign there. It's very human for everyone to find excuses or place the blame on others when tickets or crashes occur, but it's our fault. We were part of that situation. And research says that for every crash or ticket, there are 29 near crashes. That's a huge statistic. Driver error is the cause of almost all near crashes. We are at fault 9 times out of 10 when something happens. So how to keep it safe? Research is indicating that we as American citizens outlive our ability to drive safely by 7 to 10 years. So it's not a matter of if, it's a matter of when. We will all need to consider driving retirement. It's just a foregone conclusion. We're living longer and our skills aren't able to keep up with the demands of the road. So when in doubt, check it out. Consider a driving assessment. That's a two-step process, a clinical skills assessment and a behind the wheel assessment. The first part, the clinical skills, is billed as an occupational therapy assessment and is covered by medical insurance and Medicare, but it requires a physician order. A clinical skills assessment needs to be completed before a behind the wheel assessment is done. In a clinical skills assessment, we're using something called the driving risk calculator that looks at those, excuse me, 5 areas of 5 skill areas: medical history, especially medications, driving history, physical skills, visual skills, and thinking skills. There's a copy of the test sheet that I utilize. You'll notice the green, yellow, and red columns. They relate to low, moderate, and high risk potential for involvement in a motor vehicle accident. Each one of the tests utilized in the assessment has a specific statistical relevance to the performance of driving. This is not a subjective assessment. It is very objective and very specific to driving. We have several local area providers for clinical skills assessment: St. Luke's, Essentia Polinsky, Lakeview Two Harbors, Cloquet Community Memorial Hospital, and Hibbing Family Clinic. They're all using the driving risk calculator. Also, I should add to the list, Cuyuna Regional Medical Center is now doing that. Once all those tests are done, if someone has 4 or less moderate risks, they're identified as safe to continue driving. If they have 4 or more moderate risk and 1 high risk, a behind the wheel assessment is indicated. And if someone has 7 or more high risk scores, especially across all areas, and they lack insight or they're very aggressive, it's time to retire from driving. So if someone's in that moderate range, they need to have a behind the wheel assessment completed. I'm the only occupational therapist, licensed driving instructor, certified driver rehabilitation specialist north of the Twin Cities. I complete the behind the wheel assessments through my company, Safer Driver. The cost is $250. It's private pay by cash or check at the time of the service. I also offer training at $80 per hour. That would be indicative if we're recommending some adaptive controls, but if someone has to be very mild in their dementia effects of their cognition. Sometimes people will perform poorly on clinic tests, but their actual driving skills are strong. That's when we consider driving with restrictions. Minnesota and Wisconsin allow people to drive with restrictions such as daytime only, a speed restriction like roads 30 miles per hour or less, or a number of miles from home. It's added to the back of their driver's license. I couldn't find one that had those kind of restrictions, just the alcohol restrictions. If a person is stopped while driving and they're in violation of those restrictions, they will be fined and their privileges will be reviewed by the state. So behind the wheel warning signs. If someone's being stopped, cited, or warned by law enforcement, they're getting involved in accidents, even small dings. They're getting lost to familiar locations. They can't find their car in the parking lot. They're not aware people are honking at them. They're confused when it's their turn at the intersection, or they're overly angry at other drivers, or they confuse the gas and the brake, or they're driving at an inappropriate speed. Those are behind the wheel warning signs. But there are some everyday behavior warning signs. If someone's asking the same question within a short period of time, not recalling the answer, if they're doing that frequently, if they're having trouble tracking appointments and important dates and not able to use a calendar or a phone, if there's a change in their medication, they're not able to set them up anymore, they need reminders to take them, they're having medication errors, that's a big warning sign. If someone is, their personality is changing, they're less aware of other people, they're insensitive towards others' feelings and needs, and they had been a more sensitive person, that's a big red flag. If their personal hygiene is declining, if they're making errors in cooking, such as leaving the stove or oven on, if they're burning food, if they're not able to dress appropriately for the temperature, they're just not clued into what's going on around them. Those are behavior warning signs that would lead us to say, hey, there's a driving assessment needed. And my bottom line, if you ask yourself, would you allow your 5-year-old to drive alone with this driver? Would you let your 5-year-old niece, nephew, granddaughter, child ride alone with this person in a vehicle? If you can't say yes, the person should not be driving, or at the very least, they need a referral for a skills assessment. Hartford Association has a great brochure called We Need to Talk. Alzheimer's Association has some very good videos, how to have the conversation, how to initiate the conversation. But above all, if you're going to be talking about driving retirement, at the same time, you need to be talking about alternative transportation options, how they're going to get from point A to point B. If someone's unwilling to have their skills assessed or consider a different way of getting from point A to point B, you need to make a report to the state licensing body. You need to continue to offer transportation assistance, and at a very last resort, disable a vehicle. We are all at risk, and everyone on the road is at risk if that driver isn't checked out, and no one has the right to drive recklessly. So an at-risk driver, someone who's not able to safely operate a motor vehicle, a family member or a physician is exempt from release of information if you make that report to the state. You need to provide to the state the driver's full name, date of birth, the driver's license if you have it, and why you think they're unsafe to drive. You also need to provide your contact information. They will not do anything if you're not identifying yourself. Here's the contact information for Minnesota, the information for Wisconsin, and I provided handouts that accompany this session to Brenda. She'll let us know how we can access those. What happens, the state contacts the person, asks them to come in, they'll meet with them, could ask them to complete a written test, a behind the wheel test, and a written physician statement, and possibly a vision statement. I wanted to clarify that scooters, lawnmowers, and golf carts are not allowed on Minnesota public roads. Many people I'll see out there riding those devices shouldn't be. And if you have a neighborhood electrical vehicle, if it goes at least 25 miles an hour, you need to have a Class D driver's license to operate it. And lastly, if you don't think it's going to happen here, it does. This is Ron and Mary Tarnowski, who were found dead with their vehicle in 2017 on their way to their cabin. They got confused and it was a tragic outcome. These are the alternative resources for transportation in Duluth and Wisconsin, and some other resources that I've included in the handouts. So I think I went over my time and I apologize. Thank you.
Thank you very much, Anne, for giving us just a lot to think about, and and helping us kind of break down all of the different aspects of this, because I think there's a lot that we don't necessarily think about, or a lot that we might not think about as being warning signs. So thank you for that.
Sure.
Now we are going to switch over to our last presenter, Kristen Parento, to talk a little bit about the legal aspects of this. So I'm going to give me 1 second and I will get your. All right.
Thank you very much. I appreciate all the information so far. And I just put a question in the chat, and I was wondering, can you use the evaluation that you guys do to help a person that has received an at-risk driver report and is facing a driver evaluator situation?
Yes, we can. What happens is they'll ask for a physician statement, and this is how I get the majority of my referrals. The state's requiring a physician statement regarding medical fitness to drive. Physician would refer to me. I would do the skills assessment, say, yeah, this looks good to go. And the driver evaluators at the state will look at, will take the physician's word and make that decision. I'm often working with people that have suspended licenses, and we have to get a limited license good for the day only of the assessment. Very often that's the situation under which I see people.
Thank you. I know I sent some people your way, and I wanted to make sure I was doing the right thing. So I appreciate the service. So I will be talking about legal and financial matters. And I know that most of the folks in the audience are professionals. So I think a lot of folks probably are most concerned about financial and legal aspects surrounding long-term care. But before we get there, I'm going to cover just some of the legal tools that will help people have the strongest care team as possible. So we can go to the next slide. Before we do that, though, I just put a slide in here about where I'm from and what area we serve. We're a nonprofit law firm, and we don't charge anything. We cover the whole 11 counties of Northeastern Minnesota. 7 of those counties are under the Title III Older Americans Act. So which means that you don't have to meet any income or asset guidelines if you're 60 and older. So if you've got a question about this stuff, please contact us. And if it's something that we don't do, we'll help you get to the right place. So it's a win-win all around. And our intake number is the 800 number on the upper left. We can go to the next one, Brenda, thanks. So what I want to talk about is what to do immediately after getting a diagnosis and who can help you. Because that's what you want to know when you get a diagnosis. What's next? So next slide. So the first thing, do not panic. I think I always think of the Hitchhiker's Guide to the Galaxy book. Should have it on the front cover. Don't panic. You can do it. Just have to take it one step at a time. The first step is, if you wanted to make it as easy as possible, is to talk to an elder law attorney. And those are folks that talk about incapacity, disability, and long-term care. Go to the next slide. A lot of times people don't know what an elder law attorney does. They're different than the quote unquote normal attorney. We're more holistic. So we look at a person's whole life and we spot legal issues where we can help with. And with that, we know all the different programs that a person runs into when they're older, such as Medicare, medical assistance, health insurance, different things like that. We know what legal tools can help you remain independent for as much as possible and get your goals accomplished. And we can prevent problems from happening in the future as well. So that's enough about elder law attorneys. We're a good resource. Well, I guess I got one more slide about that. The whole state is covered by legal aid organizations like my organization. Each state has an attorney who does elder law. So we're a good place to start. So if you go to the website, lawhelpme.org, you can locate one if you're not in our area. And then this link next to that is, you can click on that and get to a search engine to find us. And we don't charge anything. We're an awesome resource. All right, next slide, please. So you get the diagnosis, what do? You start planning. So what's some of the stuff that you can do? Let's go to the next slide. So what I'm going to talk about briefly is the legal documents that can help you. Power of attorney, Healthcare Directive, Pulse. Those are the main 3 that people should think about. So let's talk about power of attorney really quickly before I want to get to the long-term care planning stuff. So power of attorney, the whole point of getting a power of attorney is to keep control by naming somebody who can share your authority. You're not giving up anything by doing it. They have to act in your best interests or according to your instructions in your finances and property. They have a fiduciary duty. So they can step into your shoes and handle things when you no longer can feel like you're up to it. This is immediately effective upon signing. So having this will avoid the need for somebody to go to court and get a conservatorship over you. And everybody wants to avoid that because when the court is involved with a conservatorship or guardianship, you lose some of your control. So these documents can help you get the help you need, but still retain control over your life. So everybody should have a power of attorney who is 18 years of older, in my opinion. And if you have somebody that you trust. We'll go to the next slide and I'll show you a picture of one. So this is the statutory short form power of attorney that you can get at the Minnesota Department of Commerce's Uniform Conveyancing Blanks website. Free, anybody can get it. You can also get it lots of different other places, such as the Law Help link I just showed, which is kind of a nice link because you can generate a document. You just answer questions by typing in the answer and then print out a completed form, which is very nice. So that's what the statutory short form looks like. Let's go to the next slide, please. So along with the power of attorney, on the flip side of it is your own health care. What do you use the Healthcare Directive as the legal tool to share your authority about your person and your healthcare decisions. Everybody should have a Healthcare Directive who's 18 or older, in my opinion. It avoids the need for a guardianship in the future. With a Healthcare Directive, you're naming somebody, but you don't have to name somebody. If you don't have anybody that you trust, you can just have instructions. That's good enough. And then you sign it either in front of a notary or two witnesses. The Healthcare Directive, even if you trade it now, it might not be used until a lot of time in the future. It's only triggered when your doctor says you no longer can communicate or understand your healthcare options. So until the doctor says that, no healthcare provider is going to look at your Healthcare Directive. You're going to make those decisions on your own. It's in place when you need it. So it's a way to plan ahead to get those tools in place so your team can step in and handle things the way you want it to be handled. Very important tool. And we'll go to the next slide and you can see what it looks like. So this is one version of a first page of one. So with healthcare directives, they can be totally custom made. It doesn't have to look like this. It can be as simple as you want it to be. There's many different versions. There's no standard version. All you have to do is make sure it's signed correctly and that people have access to it. Copies are just as good as an original. Contrast that with powers of attorney. You have to sign it and your agent has to sign it. And an original is best because with real estate filings, for example, you can't use a copy. So you want to keep those in a handy place at home. Don't lock them away because you're going to need to have access to those as well. All right. So those two documents will help you keep control. Everybody should have them if they're an adult. The next document I want to show is a post. We can skip the next slide. I just talked about that. So the next slide is about the post. So this is provider orders for life-sustaining treatment. This is actually a medical order that travels with you. It's not for everybody. So while everybody needs a healthcare directive, in my opinion, not everybody needs a post. It's for people who have a serious medical illness where they're expected to not survive very long, maybe a year or two. It's where you're likely to be having to call the EMTs or 911 to come to your home. the post is there so the emergency services people will know what you want on the scene if you can't communicate. It's a doctor's order, so they can follow it on scene. If you don't have one of those, the EMTs are rightly going to stabilize you and get you to the hospital. And then once you're stable at the hospital will look at a healthcare directive, but that might not be what the stuff that happened from your house to the hospital might not be what you wanted to have happened. So you want to make sure that you have those wishes on there so the EMTs can follow it. And you put them in a place where they can find them. So contact your local fire department or ambulance service and see where they would look for them. Sometimes it's on the front of the refrigerator. So I know I'm breezing through these really fast, but I want to get to the long-term care situation for payment. So those are the documents. Let's move to the next slide. So when people come to me after a diagnosis, they have all sorts of questions. They have a lot of fears and concerns. These are a lot of the questions and concerns that people have. And these are the things that an elder law attorney can answer for people. And you can also get similar answers from other places, but it's nice to talk to an elder law attorney because it's private. You're not triggering any involvement by anybody else. You can really feel free to ask any question whatsoever. It's all confidential. So a lot of times people, they don't know what Medicare pays for or not. People oftentimes believe that Medicare is going to pay for long-term care, which is like custodial care in your home or in a nursing home. It does not. So Medicare pays for hospital visits, doctor's visits, rehabilitation, if you're getting skilled care under the Medicare definition. But people only get 100 days of spell of illness to pay for Medicare. Typically, you start off going to the hospital in an emergency situation. That starts the 100-day clock. So you have a potential of getting 100 days paid for, the first 20 in full by Medicare, and then 21 through 100 partially. And then your supplemental, if you have it, will pick up the 20% that Medicare doesn't pay in that 21 to 100-day period. So that's what Medicare pays for. But oftentimes Medicare will say in that time that you're not getting skilled care anymore, and Medicare is going to stop. At that point in time, a person could appeal it right away to the Medicare oversight agencies, but you have to do it within hours, within a day, in order to have that decision reviewed. And most people don't do it. So you can repeal it. A lot of times it has stopped because you're not getting skilled care, you're no longer getting therapy or monitoring of medications to keep you stable. You're getting custodial care. Custodial care is care that helps you navigate through your day. Use the bathroom, feed, eat, change your clothes, transport yourself about the room, those sort of things. So Medicare doesn't pay for that. At that point, medical assistance pays if you're eligible. So people want to know, well, am I eligible? What do I have to do to become eligible? When I do become eligible, what's going to happen to my house, that sort of thing. What happens to my spouse? What happens if I made a gift to my children at some point in time? Maybe naming their children onto their house deed or just Christmas gifts of cash every year. How does that impact everything? All those questions I can answer. So the important thing though is, if at all possible, if you could get that information about how long-term care works early, you can do some planning where you could possibly make some strategic planning where you could gift something to children, like put a child's name on a house deed in order to avoid having to sell it if nobody is there, no protected person happens to live there in the future. If you do those things early enough and outlast the look back period, the county won't see it. They're not concerned about it, and you won't have to be ineligible for medical assistance. So there's lots of things you can do to plan ahead for these things. So I just want to, I'm looking at the time. I think I have till 2:30, right, Brenda? Yeah. So the house is a big deal for people. So what I want people to know is as long as there's a protected person living in the house, it is not going to be a problem or a concern, either for eligibility or having to sell it. A protected person is a spouse of somebody on medical assistance. It's a sibling of that person who also lives there with an equity interest in the home. It could be an adult disabled child, a disabled child of any age, actually. Those people are protected. So if they're living there, the county can't make you sell it. For example, if the home is in one person's name only and that person is going into medical assistance, normally after 6 months of long-term care, they'd have to put it up for sale in order to become eligible or retain eligibility for medical assistance. They don't have to worry about that if a protected person is living there. So if that person's getting medical assistance in the home, like through elderly waiver, no problem, because they themselves are the protected person. But if they're in the nursing home and their spouse is living at home, the house is still okay because the spouse is a protected person. So if there is a forced sale needed, the county's not going to take the home. They make you sell it and use the proceeds towards your cost of care. So they don't get the proceeds, but you're not going to get medical assistance until you spend down to your eligibility limit as a couple. And right now that's about $133,400 roughly in countable assets. So once you spent down to that amount as a couple, you're eligible. But the house is not counted until there's no protected person in it. And then of course, I know we got 4 minutes, people have concerns about medical assistance liens. So what I like to talk about is medical assistance on the front end with eligibility, what happens while you're on medical assistance, and what happens afterwards, after you die. That's medical assistance recovery for benefits paid out. So that's through liens and through estate recovery, probate, in other words. It's only for medical assistance that you received from age 55 and above, and for long-term care services and support. So it's not going to be for that medical assistance that's the Affordable Care Act medical assistance where you're getting healthcare, a healthcare insurance plan that lets you go to see the doctor, for example. It's not like a Blue Cross Blue Shield type of medical assistance. This is where you get somebody coming in to your house where you're getting actual services at the age of 55 or older. So those are the benefits that the state has a claim on to get repaid on. So there are ways that you can minimize that if you do some planning ahead of time. For example, a medical assistance lien on a home only attaches to the interest that the medical assistance person owns at the time of their death. So if they're, instead of owning a full interest in the house, they can own a partial interest, like through a joint tenancy or a life estate interest. So those are things that you could do ahead of time if you had some chance to plan rather than do some crisis planning. So that's why once you get a diagnosis, and that diagnosis logically has a progression where it's feasible that you're going to need to have long-term care in the future, you should go talk to an elder law attorney to do some of those planning things where you can protect some of your assets. I think we're 1 minute shy, so I just want to go to skip ahead I want to say reach out for help. You need a will, maybe, maybe not. It's not essential for planning. There's other ways to do it, but it's never a bad thing to do. So let's go to the reach out for help stuff. Slides at the very end. It's the next one after that. So I just want to say, like Danielle said, caregiving is very stressful. You got to look out for yourself as a caregiver because it can lead to elder abuse. There are people out there that can help. Caregiver consultants are wonderful. They can help you see what services are out there, what you need and what you could be eligible for before you call the county. Senior linkage line, indispensable. They're a wonderful resource. Call them for anything basically, and they'll get you the right people. If you want to do some searching on the computer, minnesotahelp.info, they vet the information that goes on there. So all the contact information of programs are valid. Support groups, wonderful. People have gone through this before, learned from those folks. Lean on family, friends, and others. They want to support. Oftentimes they don't know what to do. Tell them what you need. It'll be a relief to them so they don't have to guess. So that's what I wanted to talk about. You're not alone. Knowledge is power. There's people out there that can help you get that knowledge. Please reach out. And thank you for attending. Thank you, Brenda.
All right. Well, thank you very much, Kristen, for, I know it was quick, but thank you very much for kind of filling in some of the areas there with the legal planning. And I do want to mention that we have been lucky enough to have Kristen be a couple of other sessions with us in the past. So we've got ones on our YouTube channel of Kristen talking about advanced planning. We've got ones talking about spending down to public programs. So if you've got more questions on those areas, that's a really good place to start. And then also, obviously, getting in touch with Kristen at Legal Aid Services if you find that you need some assistance as well. So do we have would anyone have any questions before we kind of get wrapped up? We will be doing, you will get an email from me that will have the information, the resources that Anne mentioned, as well as a link to the recording of the session. Please feel free to, if you want to go back and watch it again, if you want to share it with other folks or with clients and things like that. I think it's a really good, it's a really good, easy way to use those things. Let's see if we've got anything. Oh, not any questions right now. Well, with not seeing any questions, I want to say thank you to Danielle and to Anne and to Kristen for joining us today and for being part of this and sharing your wealth of knowledge and hopefully giving people in a scary situation a little bit of a life raft there and a little bit of a some good resources to start with and a good roadmap to kind of think about what their next steps forward are going to be for them and for their families. So thank you guys so much for being part of this and for joining us today. Please keep an eye on our Facebook page or on our website at arrowheadaging.org for other upcoming sessions. We're going to be doing ones, I think, on elder abuse and on food security issues and transportation in the region and things like that. So we've got some great resources that are available for folks. So again, thank you guys for joining us. Thank you everyone else for joining us. There will be a survey when you click off from here. And so please share with us information about what you like, what you don't like, topics that you'd like to learn about so we can give you the information that you want. So thank you so much. Have a great day.
Thank you.